to start today's session with a land acknowledgement. I am joining from the ancestral homelands of the Beothuk, whose culture has been lost forever and can never be recovered. The island of Newfoundland is the unceded traditional territory of the Beothuk and the Mi'kmaq, while Labrador is the traditional ancestral homelands of the Innu and Inuit. And we recognize all First Peoples from coast to coast to coast who were here before us and those who live with us now and the 7 generations to come. As First Peoples have done since time immemorial, we strive to be responsible stewards of the land and to respect the cultures, ceremonies, and traditions of all who call it home. As we open our hearts and minds to the past, we commit ourselves to working in a spirit of truth and reconciliation to make a better future for all. Thea, can we have the next slide, please? So today's agenda, we will have Micah Asselsberg to speak on behalf of Patients for Patient Safety Canada. And then we have the team from out west, from Alberta Health Services Calgary team, and a representative from Bethany and a representative from Carewest to talk about an initiative that they have been working on. And as Anne said, we saw a dry run of this presentation the other day, and I think there's some really exciting information in here to help with discussing patient safety with clients and doing it in a co-designed way. But there's also pieces of this I think are really good for just measurement and monitoring of safety in a general way. We'll spend some time then in a bit of an open discussion where we can have some questions back and forth. And at the end, we'll do a quick check-in on measurement, monitoring, and safety, and then some closing remarks. So before I turn it over to Micah, I'd like to introduce Micah to you. Micah joined Patients for Patient Safety Canada in 2016 to contribute to improving safety for patients. She is mostly retired, having previously held executive functions in voluntary health sector and served as a senior consultant in voluntary health research and with government sectors. And on top of that, Micah's been involved with this work right from the early stages, right from the beginning, really, with our demonstration project and then into the Learning Collaborative. And it's been a joy and a real privilege to work with Micah on this work. So, Micah, over to you.
Good morning and good afternoon to those of you across the country. I think I need to replace that picture with a more accurate one. I've aged a number of years since then. Thank you so much for the opportunity to contribute to today's webinar. I'm, as Wayne has mentioned, a member of Patients for Patient Safety Canada. I'm also an engaged patient who partners with other patients and professionals in undertakings to improve safety in healthcare and in my own care. Patients for Patient Safety Canada, as a number of you may already know, is the patient-led program of CPSI. A complicated health history, several key misdiagnoses, and an instance of medical neglect have schooled me over a lifetime to understand my own responsibility for and my role in enabling safer care for myself. My involvement as a patient in the introduction and application of the measurement and monitoring framework over these last few years consolidates much of what is important to me in patient engagement and safety improvement. As I see it, the framework offers great promise to make a significant positive difference in the future safety of our care because it rewires our thinking about safety and actively engages patients, family, caregivers, and all others involved in care in a new way. It can serve as a means for organizational and individual capacity building. It calls on us to answer in the moment whether care has been safe in the past, whether care is safe today, whether our clinical processes are reliable, and whether care will be safe in the future. It also asks whether we're responding and improving based on what we're learning. I see the framework as a means for engaging patients and all the other members of the team, the healthcare team, day to day, in a meaningful, focused way in dialogue and action on safety. Engaging in conversations about safety with patients is evidently not easy. It will take commitment, sustained commitment, and a better understanding of how patients and their caregivers see risk of harm and what feeling and being safe means to them, to us. A current research undertaking commissioned by CBSI explores safety through the eyes of patients and caregivers. The intended outputs constitute a key piece for equipping the uptake of the framework more widely. I'm passionate about what the framework offers for a necessary cultural shift in how patients engage in enabling their safer care and how all involved in that care think about, plan, and equip that shared quest. As one of 3 patients on the Research Advisory Committee for the project, I also serve as co-chair with Professor Ross Baker. It is one of countless examples that has patients meaningfully engaging in and contributing to safety improvement efforts, and not just serving as window dressing. On a personal note, as someone who lives with a number of health issues that need ongoing attention, I've used the framework in my own care and in the end-of-life care of both of my parents. It provided such a helpful set of reference points for thinking through, monitoring, anticipating, and proactively addressing and/or responding to each situation. Confronted with a high-risk health situation of my own just over a year ago, I again used the framework to focus on what mattered and to inform decisions about care. In closing, I want to thank all of you for what you do in service of patients and residents in care settings and towards building a safer care system alongside and with patients and caregivers. For you to continue to do so in these circumstances of the pandemic only underscores my gratitude. Thank you. Over to you, Wayne.
Thank you very much, Micah. It's beautiful words. I'm going to move now to our presentation here today, and we have 3 speakers joining us. Jennifer Lee is a senior quality consultant in Alberta Health Services. She is an occupational therapist and has worked in the continuing care sector for 10 years in clinical and operational roles. Jennifer is passionate about innovation, quality improvement, and governance. Stephen Friesen is the Director of Quality Clinical Education Research at Bethany Care Society. He has held research and evaluation positions in Alberta's public and nonprofit healthcare sector for more than 20 years. His professional experience includes broad focus on health services and system research and program evaluation across primary care, continuing care, and acute care settings. And Yaro Kisovlev is a senior executive leader for the past 5 years. Yaro has worked in healthcare operations and continuing care and community with Carewest. In pursuit of innovation, Yaro has developed skills and interests in design thinking, applying this methodology to numerous operational reviews and restructuring initiatives that he's been part of. In addition to holding a Bachelor of Nursing and a Master's of Arts in Leadership degrees, Yaro is also a certified health executive with the Canadian College of Health Leaders. So welcome, and we will turn this over to Jennifer. I believe you're starting off, right?
Yes, good morning, everyone. Just bear with me a moment. I'm just going to share my screen, so let me know when you're able to see my screen here.
It's up for me, Jennifer.
Perfect. So good morning, everyone. We are very excited to present to you a project that we've been working on for just a little over 2 years now. And this project is known as Co-Designing Safety Conversations with Staff, Residents, and Families. And so this is the core team that worked on this project, and you'll meet two other of my fellow collaborators right now. And so Yarrow, over to you to talk about Carewest.
Sure, thank you, Jennifer, and good morning, everybody. So Carewest Signal Pointe is a continuing care facility that was built in 1999. For the first 10 years of its service, it served primarily dementia care as well as brain-injured individuals suffering from those illnesses in the community. It is a purpose-built facility, one of very few across the nation, actually, and we still get lots of interest from other provinces coming to see the site, because it is set up with the Eden philosophy and very much has sort of that community feel as opposed to institutional feel. It has 5 separate homes with the main street hallway, and is set up to feel and look like a real community for the residents that live there. Over the last 7 years or so, Signal Pointe has transitioned from dementia care into more of a mental health care facility, admitting much younger individuals suffering from various forms of mental illness. And so as a result, there's been a shift in the model of care at the site, having much more mental health resources focused on meeting the needs of care needs of the individuals. And we have single occupancy rooms and capacity for 54 residents. There is about a 2-3 year wait list right now for individuals in community and the hospitals to be admitted to such facility. And so it's one of very few sites that offer this level of services in Calgary zone.
And thank you, Yarrow. So I'm just going to give you a quick overview of Bethany Riverview. So Bethany Care Society, so we're about a moderate long-term care provider in Alberta. I've got about 8 long-term care sites, a handful of independent seniors housing and supported living sites as well. So the site that participated in this project was Bethany Riverview. So this is a relatively new site, kind of an evidence-based design that opened up 2018 in September. So it's just over 3 years old. It is actually a combination of long-term care. So you can kind of see the picture. There's 4 floors. The top floor is the long-term care end. Each house has about 30 beds, so 60 beds across the floor. So a total of 210 beds. The middle 2 floors are actually a complex dementia care program, which is relatively unique in the province. So it's a specialized program funded through Alberta Health Services. The units that participated as part of this project, again, were those more the long-term care side. So again, as we were opening up a new build, this actually a relatively large space. And as the large space with the independence and privacy is one of those key design criteria, what we found is that there was a lot of opportunities to reframe some of the safety challenges that we were having with a new environment compared to some of the previous older kind of environments that we were supporting those same programs in. So a lot of these residents, again, moved from a previous older building that we used actually to kind of set up some of the programs and services for this new build. Sorry, pass that over to you, Jen.
You're muted, Jennifer.
How's that? Can you hear me now? Okay.
Yes.
Give me 1 second. Let me just blow my screen back up here. So just for the group to know that this was a physician-led project. So Dr. Vivian Ewa was our physician lead for this project. And so really what we learned from the MMSF is that resident and family engagement is a really fundamental part of this safety framework. And so this entire project was based around that core central idea. And what we know is that in long-term care, these safety conversations are happening in a very structured context. So for example, safety will often come up in resident and family conferences. And what we really want to do with this project was expand that and support that so that safety conversations could also happen beyond that structure. And so we really worked with residents and families and also care teams of both of these sites that you just heard about to co-design materials that would really support those conversations more broadly. And we're working with 2 long-term care organizations that do have similarities in terms of their safety, but they also have a lot of differences in how they operationalize safety in each of those organizations. So one of the challenges that we had with this project is that we had to find a solution that was general enough that it could be applied to both organizations and potentially others, and it wasn't tied to one specific process, but it had to enhance the existing safety processes of both of these sites. So in a nutshell, that was our design challenge, is co-design materials to support safety conversations between care teams, residents, and families in long-term care. And so the methodology that we use to support that co-design is this method known as design thinking, and it underpinned our entire project. And so two of the things that were really important about this model that we kind of brought forward throughout the project is that there's a strong focus within design thinking on really understanding the user. And so we started the project by doing a number of different things to really understand our users in this case being residents, families, and staff. And then, so I just want to start by giving you a taste of how design thinking really helped us throughout this project. One of the things we use is something called a persona. And so this is our spouse. So imagine that you're Juliana for a minute, and you're the wife of Bob, who has dementia, and he's been in a long-term care center for a year. And when Bob first came into long-term care, Juliana was really worried that if he had behaviors, staff might try and tie him down to manage those behaviors. And that's what happened to him in hospital. But staff in this long-term care environment didn't tie him down. Juliana visits every single day, 12 hours a day, 7 days a week. She's always there. She takes an active role in making sure that Bob is safe, and she's very involved in his care. And what she has to say about it is that she lives this reality daily, and surely we can have some input on safety. We may help with the safety of our loved ones. And so now I want you to step into the shoes of Jana. She is a healthcare provider on Bob's unit, and she loves working with seniors, and she treats all of her residents like they're her own family. And she often works with families that expect a lot of personalized care, but she really struggles with that because she wants to deliver on personalized care, but she has so many residents to care for that she just can't keep up. And so she's got 30 other residents who also expect personalized care. And so that's one of the challenges that she has in our day. And so personas help us understand who our users are, and they're composite of and so the two that you just saw are a composite of all of the healthcare providers that we interviewed, as well as, in this case, the families that we interviewed. So they're a composite drawn from all of those interviews, and that really helped us understand who our users were. The other thing that was really helpful was the journey map. And so a journey map, just to orient you to this picture, is a very visual tool that further articulates the resident's experience. And in this case, the journey map that you're seeing on the screen is the resident's experience from the spouse's eyes. And so again, this is a composite of all of the interviews that we did with the resident and the family. So I'm just going to zoom in very quickly on one section of this journey map so that you can have a little bit of a closer look on what that looks like. And so this is just a section of it. And so the purple at the top is kind of the key points of their journey. The blue kind of describes what some specifics of that journey are. And then we have some key quotes again from our interviews, just to give whoever's looking at this journey map a sense of what that journey looks like and what people think and feel as they're going through that journey. So again, this journey map was another tool that we used to help orient us to, that user experience. And so looking at all of those documents that you just saw, the personas, the journey maps, as well as the interviews, together we learned a couple of key insights. The first one is definitions of safety. I'm going to come back to that one because I'm going to expand on that a little bit. One of the other things things that we learned is that by the time residents and families move into long-term care, that's their last stop in the healthcare system. So there's been a whole journey before that point in the healthcare system that we often don't really think about or spend a lot of time asking about. But what we learned is that that has a fundamental impact on how residents and families think about safety. So by the time they get to long-term care, their perceptions of safety are fully formed by their previous experience in the healthcare system. And that was a particularly key insight for us to be aware of. Number 3, staff really go the extra mile for families and residents. And when we were interviewing staff, what came out was all of the extra ways and all of the things that they did within their workflow to try and accommodate, as you saw, some of those demands for personalized care. So it was very clear that staff were really doing their best within their resources, within their work environments, to try and accommodate families and residents as much as possible. And number 4 is that your unit culture really affects your safety. And so again, that was another key point for our project, because we had to be cognizant of the unit cultures when we were co-designing this work. So just going back to that definitions of safety point for a moment, that insight, we just wanted to expand on that a little bit. And what we learned when we looked at those resident and family interviews and the journey map and the personas side by side with the healthcare providers, personas and journey maps and interviews, is that families and residents have a very different viewpoint of safety in comparison to healthcare providers. And so on the left here, you see this comment from a family member who says, she's always liked her hair curled and they aren't picking it every day. So they really look at safety and define safety by personalized care. So if you're able to pick my hair in the way that I want it to be done, that means you're providing safe care. And then in contrast on the right, this is a quote from a healthcare provider. Their definition of safety is that there's good care planning and follow through. There's safety checks happening on residents. They have a proper diet, and that they're well cared for in a safe environment for them. And so when you talk to healthcare providers about what safety means to them, they're really looking at it from a very clinical perspective. And so what that means from the context of our project is that you have 2 users who are fundamentally approaching safety from a very different lens and a very different angle. And so both of those lenses are important. And so it was something that we had to really think about and incorporate into our project. And so Yarrow, I do believe this is your slide, so passing it over to you.
Great, thank you, Jennifer. And so we booked a design sprint with the team, which was somewhat modified. It took place over one day at a central location here in Calgary, and we invited both teams from Bethany as well as from Carewest, and we had some folks from AHS. And what really was remarkable is we had individuals from frontline level staff to resident families actually that attended, as well as senior executive leaders. And so this method really allowed us to break down some of that hierarchy and really say that we're all in this together in terms of our goal and our focus, which is to ensure that we have resident safety. And so the design sprint had its layout through different phases of the day. We had extremely rich dialogue, and again, just an ability to be able to gather a variety of perspectives through that dialogue and be able to see different sides of the same coin through different lenses, both from a care provider perspective as well as family and leadership perspective. We began, as you can see in some of the photos, began to do some empathy mapping to see, where do we have some of the themes or some commonalities amongst stakeholders involved, and using some of the visuals that you see here on the screen as well to begin to paint that experience in as vivid terms as we could, so that we could really hone it down to what was the key nugget for us to take away and begin to build further, which we'll get to later on in this presentation. So I'll throw it back to you, Jennifer, for the next slide and some of the outcomes of that work.
Yeah, and so maybe I'll just start by explaining what a prototype is. And so basically, as Yara mentioned, we locked all these providers in a room for a day and said, you know, you're not leaving until you come up with the solution. And so they came up with 2 solutions. And so we call those in the design thinking sort of terminology prototypes. And basically what a prototype means, and you'll see this evolution over the next couple of slides, is that we come up with an initial idea. We take it out, we test it in a very limited manner, and then we take that feedback and then we change the prototype again. And so we keep going until we feel like we've landed on something that meets the user needs. So prototypes are really not fancy. And so, you know, at this point in the project, I was spending a lot of time in the dollar store. And so prototypes are dollar store creations, cardboard and duct tape and construction paper. And so that's really what a prototype looks like. And that's one of the beauties of this methodology, is that it's not intended to be a pilot. It doesn't involve terms of reference. There's no steering committee involved. It allows you to take an idea, go out and test it very quickly, and then take that feedback, shift it again, and then keep testing it all the way through. And so in this picture, so the staff who were at the sprint that day came up with 2 prototypes. One we just simply called at this stage a triangle. And so the picture you see on the left is that triangle. And basically it was loosely based on a Maslow's hierarchy of needs. And so there were questions associated with each section of the triangle. You can kind of see that it's broken up. And then it was intended to be a visual representations of some of the things that were important to the resident and the family from a safety perspective. And so for that first prototype, I just took what you see there and drew it a little more nicely, put some colors on it, and then showed it to residents and families and staff and said, what do you think? And so what you see on the right is some of those thoughts. And so they said, what if we make this a poster size? And then you had staff saying, well, if you have it on this legal piece of paper, it might just be another thing to look at, and you know, people might not look at it. And so valid feedback. The other prototype that the staff that day came up with is this cards, is what we called it at this stage. And so essentially what it was just a bunch of pieces of papers with various questions that staff felt might be important to ask or to have a conversation about with safety. And again, we had residents and families. So again, took these pieces of papers with these Sharpie questions, turned it into something just a bit nicer, and then threw that at residents and families and staff. What do you think about this? And so here's some of what they said to us. You know, staff who designed these questions were very uncomfortable and or are afraid of the answers for some of these questions, which is a very interesting finding. The other thing that we got is that, you know, some of these questions are really personal. So maybe we start with some more general questions for rapport building, and then we move to more personal questions as we get to know people. And so that was the feedback we received for these 2 prototypes. So let's evolve it. And again, nothing fancy. So here we go. We took that legal size triangle and we turned it into this. And so this is a poster size triangle. And then we showed up at our next testing session with residents, families, and staff and handed them a bunch of stickers. Okay, so here's stickers that might simulate what you might expect of this triangle. So let's try that. What do you think now with how this looks? And so some of the feedback that we got was change the order of the questions. Very interesting feedback. Is the top of the triangle the most important part that we should be paying attention to, or is the bottom part the most important? And so, you know, real debate when we were testing this on if you read this top down in order of importance or bottom up in order of importance. You had families also tell us that they felt that this triangle could be a real bonding experience with the resident to complete. And in fact, what we realized is that many of the residents at Signal Pointe and at Riverview that we tried this on weren't able to complete this independently. And so really it was the families supporting the completion of this along with the residents, and that was really lovely for them. with the cards. And again, here we are. We showed up with something a little bit more fancy, and we shifted based on that feedback. And so when we showed this to families, what was very striking is that at this stage, those cards evoked really strong emotions. And, instead of giving us feedback on the design and how it looked, and on the questions, they just started asking and answering the questions amongst each other. And so some of the responses that we got were, I'm afraid to ask the staff what stage my wife is at in her disease trajectory. Was one response we got. Another that we got in testing was, I'm afraid to ask what happens to me when my husband dies. So just some really powerful responses. And so when we got that kind of feedback, we knew that we had at least hit the nail on the head in terms of the questions. And so here's the final prototype. And again, this happened just before the pandemic hit back in March. And so we were only able to do 2 iterations. But here's the final prototype of what that triangle looks like. And so the key here is really in a poster size format that would be posted in the residence room. They would complete this triangle using whatever tools or materials that they felt might be helpful to kind of illustrate their points. And so the questions that we asked them to reflect on and complete for were from the top down. A good day for me is, I'm the most proud of, important people in my life are, what makes me feel safe, and what do I need every day? And so again, to help start a conversation with staff, and so that staff could sort of understand what this person was about. Here's that final prototype for that cards, and it ended up being called Conversations About Safety. And so it went from individual cards to one single card that could be put on the back of someone's work ID. And so we sort of color coded the questions so that you would know to start with more general questions and then go all the way down to, these deeper questions once you got to know the person a little bit more. And so, for example, some of the questions from each section are, my person in care likes to, a favorite memory is. In the connecting box, we have, I expect staff to, I expect families to, and then we have these deep conversations. One question I've been afraid to ask is, I feel guilty when. And again, these are to support conversations amongst staff, so it's on the back of their ID. Also meant to be given out to residents and families, so again, they can start these conversations. Steve, over to you.
Thanks, Jen. So I think some of the project outcomes, some of it, we went into this project, again, we've got a relatively long history. Bethany Care Society is a 75-year-old organization, so lots of culture. So opening up a new building, I think what we found is that trying to reestablish that culture, even when we had to transfer staff over, it took a little bit of effort and work. So when this project came up, I think what we recognized is that some of the unintended consequences that we were really able to challenge kind of a little bit of a deeper dive on how we could support a better and more consistent understanding around how do you support a safety culture. So this actually has resulted in some real rethinking around how we align that safety culture education across the whole organization. So just the practical application of the measuring monitoring framework through this project, we recognized that there was a greater awareness of staff in terms of how to apply this concept of safety and really into kind of cultural change. So it's now actually spurred on to more education priorities across our organization for sure. And we know that Carewest had already adopted, and AHS was already doing this as well. So it was a nice alignment with this project. The other one that with the engagement of residents or with family members and staff, I think this notion of prototyping where there was a much more opportunity for shared decision making. A lot of times when we do these kind of projects, I think we move kind of forward with a little bit more of an applied solution, and we're really looking for feedback on implementations. So I think what we found is that in developing these solutions in collaboration, we got to this far more kind of person-centered approach that I think is what we always intend to do with a lot of our projects. But again, I think using the design process, it allowed for this much more collaborative understanding to co-design a solution together to get at a solution that we wouldn't have, I think, addressed by piloting and reiterating and evaluating solutions. So I think just the approach really helped us kind of challenge our QI approach a little bit with the design thinking. And with the advantage of having the core team with HS and a bigger picture kind of systems level support, again, I think we were able to dig a little deeper. I mean, I was fortunate to be part of some of the the interviews when we're going through the prototypes. And I think, again, we do a lot of great work, and we've got great teams within the industries to support QI. And I think a lot of times we hope to get at some of those cultural change. But a lot of times I think we scratch the surface because we end up kind of more dealing with more process or practice-based kind of challenges. So I think having some of those external, bigger picture opportunities to have much more deeper conversations on really what's happening and why these processes are working the way they are. Those external pair of eyes and expertise, I think, really allowed us to kind of get a little deeper and start flagging what does safety culture look like, and is that something we can do a little bit of QI work on. So I think those are some key ones that kind of flag for us, and I think it's over to you, Yarrow.
Yes, thanks very much, Steve. And yeah, just want to echo actually the fact that I think the journey from the prototype to actually actioning something is much more direct with the design thinking methodology. So I think we as an organization are learning lots about design thinking and how we can apply it to other forms of internal research and internal QI work. So I'll speak briefly to the organizational factors that are critical for those safety conversations to take place. And there's a couple of slides on this. I'd like to open by saying that I think a lot of these factors are not dissimilar to some of the research out there on employee engagement and positive organizational culture. I think there was an overwhelming feeling that the employees, when they feel supported, when they feel like there is an open door policy, and both from not just the employees, but also families and residents, that you develop this quite therapeutic relationship with everyone involved and really get that sense of community where we have similar goals, similar ideas, but also can challenge one another if things aren't going well. And certainly I can draw on some examples where we have conversations with guardians and families around whether it's care needs or safety. More specifically, I give you an example that, for example, we might have a younger adult moving into a site with a 78-year-old living across the hall from them, and how do they get along given that they have different behaviors and different care issues? And so those pieces, as far as how we set this up as leadership, is quite critical to those safety conversations being rich, but also being meaningful for both the resident, the family, and the caregiver. With that said as well, we did mention both formal and informal leaders in this project outcome model. It's important to recognize that we have a lot of informal leaders that have just as much authority in a way as the formal leaders do because of their ability to navigate complex decisions and complex behaviors and be sort of the lead on site when management's not around. So it is important to remember that it's not just the manager or the director that holds the key. We have a number of people, again, at the level of healthcare aides, nurses, therapy staff, that step up and can role model some of that positive behavior to ensure that we have that space to have those safety conversations. Next slide, please. And so what it really comes down to with these other 2 points is just having space to listen, being able to set space with the residents and families, both at a group level, whether it's a resident family forum meeting or whether it's a group conversation, as well as individual conversations, but to allow space and time for that. Oftentimes we expect our staff, for example, to do things on the QI side, for example, that are part of their workday, and it's often hard to schedule that in given how busy the care needs are, especially during the pandemic. And so it's important for leadership on site to be able to allow for that space to take place. And so some examples of that might be formally scheduling or bringing in people from home on their day off for half an hour or an hour to have a purposeful time at the site to work on these things. And that's a commitment that's required both from the site and the organization at large as well. And back to you, Jennifer.
Yeah, I just want to quickly at this point acknowledge that, this project was grant funded by the Chief Medical Officer Quality Innovation Fund, and without their, support, we would not have been able to do this project. And there were also 2 key individuals who also support this project for us, and that is Anne Hannemeyer. She's the Director of Integrated Supportive and Facility Living, and so she was very instrumental in working with us, as well as Abram Gusher, who is currently the manager of Seniors Health Strategic Clinical Network, but at the time of this project was working very closely with us as well. And then just a huge thank you to both the residents, family, and staff at Bethany Riverview and Carewest Signal Pointe. They were really the heart and the soul of this project. Over to you, Wayne.
Thank you so very much, Jennifer, Yarrow, and Stephen. You know, it's one of these projects that when you see it presented like that, wouldn't you just love to be in the room for part of those sessions, just to see the interactions and the dynamics going on, the conversations that occur. It's always so nice to see when things are done in a generative way. We have people joining us today online who are part of the research that is ongoing now that's being sponsored by CPSI. And it is the research that Micah made reference to earlier, how safe is your care, measurement, monitoring safety through the eyes of patients, families, and their caregivers. We have Dr. Ross Baker, Micah, and Leanne Jeffs with us. And I'm just wondering if one of you might like to make a comment or have a thought or a question before we go to a more general questions. So just provide you guys with a chance to ask a question if you'd like.
It's Ross here, Wayne. I thought that was a great presentation, and I really appreciate that effort. I just wonder if you could tell us a little bit more about what the reactions have been from patients and families to this effort, and any additional sort of changes you made on the basis of those initial reactions and using the cards and the poster to try and create greater engagement, a greater understanding of safety with them.
Yarrow and Steve, do you want to answer that one?
Sure, I can start that question off if that's okay. So we actually, if you walk through the site right now, so as you walk into the town hall area, as we call it, which is sort of the main hub where the residents and families might congregate or might spend some time, we have about 6 or 7 posters on the wall just to be able to be conversation pieces, and families have agreed to put those up in more shared spaces as we try to get more ownership of this project at the site. And we even had somebody from leadership team, from staff, to complete their own posters to say it's not just for residents, families, but here is my life story, here's my perception of safety, because although this project was focused predominantly on the patient safety component of it, there is an integral link, I think, between the staff and resident safety, and just really having that sense of community. And so it has allowed us to project ourselves and be vulnerable somewhat, to be able to say, here's our perception of safety, what is yours, and to have that conversation with families. And so I think the feedback has been very positive from a couple of families I've spoken to recently, and saying, this allows us an avenue to be able to communicate concerns or communicate components of what's important to my loved one when they're in care. In other ways, we haven't been able to reach that level of the depth of dialogue using our internal processes, which we also have on site. This gives us a much more robust way to have that conversation.
Maybe I'll just add, one of the we had the advantage of actually having Jennifer presenting this to one of our resident family councils at Riverview, and engage families for more dialogue around how do we actually apply this. So we took the window of time, but unfortunately that was just ahead of the fall when restrictions kind of came back in again. So when those first level of restrictions started to kind of weed back a little bit, we were hoping to make that an opportunity to start some of that engagement and that application of the learnings that we had on how do we start to break down some of that those barriers that we were seeing between our staff and our family members, to have some of these more shared conversations that kind of get at the root of some shared values. So we do expect that hopefully now we get over this next hump, over the, when now the vaccines are kind of out, we can pick up where we left off. But I think there was a lot of enthusiasm. I don't know if you want to add anything, Jen, that there was a lot of feedback, and again, we appreciate Jen's ongoing support and participation, because it was a one-year project that I know we've kind of extended on with the pandemic. But I know there was a lot of enthusiasm by the family members and the staff to continue on with these conversations, which again is great.
I think one of the things that was interesting, especially early on when we started doing more in-depth interviews with families and residents, they were just relieved that someone wanted to hear about what their journey had been like and what their experience had been in long-term care to date. And they were just so glad to be given the opportunity to speak to that. I think when I talked to many of those spouses, most especially, they were just relieved to be given the opportunity to share their thoughts. And there were a lot of things that they were doing, sometimes noticed, sometimes unnoticed, that were also helping preserve the safety of their resident or their loved one from their perspective. And so again, having the opportunity to share those things was just really meaningful to those families and residents.
And Wayne, it's Leanne. Just a comment overall. I think Carrie's online as well as Anna and possibly Virginia. Your presentation is extremely important, and it really is an example of co-design and design thinking in terms of coming up with a persona and a whole new world that I think many of us in healthcare with related to innovation and design thinking, co-design. So I want to commend you on that too. And as Micah had mentioned too, Micah and Ross are the co-chairs of the advisory group, and I know Carrie's online too. And we're looking at trying to make the framework more actionable to patients and care partners, and we'll be hosting a World Cafe in the next couple of months too. And I think the examples, hospitals coming on. Anyways, and look forward to reconnecting with you after this as well to see how we can incorporate your learnings into actually making it more actionable across Canada.
Thank you. I'm going to open it up. If you have a question from the general group, you can use your hand function in the top panel, and we will try to, between Thea and I, we'll try to monitor the box. While we're waiting for people to be brave enough to put up their hand, I have a quick question for you. I really, when we went through this in the dry run, and I've been thinking about it ever since, is this idea of the three levels of questions, the rapport building, the connection, and the deep conversations. Can you just speak a little bit more about that? Because I think there's a deep insight into that, because lots of times we throw stuff at people and we shut them down because it can be oftentimes very heavy for them. But just the fact that you recognize that, I think is fairly important.
I'll start, and then Yarrow and Steve feel free to jump in. But I think it was based on a core insight that we had. Like, you would never approach a stranger on the street, generally speaking, and just say, like, tell me your deepest, darkest secrets. Like, you would never do that in real life, but there's a huge power differential in healthcare. And so we expect people to be able to tell us, or from speaking as a provider myself, like, you expect people to be able to tell you your deepest, darkest insights, because you might potentially or not need that information to provide care services. But in normal contexts, that's not something that you would do. And so the reason that we chose to structure it that way was an acknowledgement of the fact that you can't ask these deep personal questions without first building a relationship and building some trust and building some rapport there. And we had residents and families telling us that was the most important piece, and being able to recognize faces and names of staff and to know who they were was important to them opening up. Steve and Yarrow, anything to add to that?
I can flag that, and again, I was kind of fortunate enough to be part of some of those interviews, and it definitely was quite apparent when certain questions were asked. It just elicit a far greater kind of depth of conversation. So I think when the analysis was kind of going on, we could see, well, this is a level of kind of deeper engagement that really requires a level of rapport. And I think when we heard for some of the feedback from staff is that in some cases, they didn't really see that rapport was always clearly established. So we thought we probably need some cues in order to kind of get some of those initial relationships, knowing that those conversations, that once we ask some of those questions, it has an opportunity to elicit a much deeper conversation. So I think that was kind of the aha moment to say families were definitely wanting to have those conversations, and I think staff also want to, but we needed kind of a little bit of a stepwise process to kind of get into that.
It's interesting because when we do the work in the learning collaboratives, we send teams back to have safety conversations with teams, and I think there is some real direct learning from your cards there that I think we can learn about and apply to the work that when we ask people to go back and have safety conversations, there is this need to really start off by rapport and then connecting and then getting into some of the more challenging areas. So even staff to staff, or middle manager or unit manager to staff, I think there exists this need to build a rapport. The other question I have for you is I'm just wondering about with all the changes with COVID, are there learnings that might be applied from this project to a COVID response?
Maybe the one thing I can add is that I know what we've continued to try and have challenges with is having those engaged conversations, usually around our palliative care process. So as disease trajectories start to change, it assumes you've got those deep conversations already in place. And I think this is what we learned is having those relationships and those conversations ahead of time ends up being something that's a bit of an investment in order to have those deeper conversations when we start talking about palliative or end-of-life care. So I think this has ended up being a bit of a catalyst for some other conversations for programs that we know already we're trying to figure out how do you support that much more consistently. And I think this was giving us a bit of a catalyst for that kind of work.
There's just a question in the chat box, Wayne, from Carrie. She is wondering, how do the findings from the conversations inform ongoing QI?
I'll speak from the AHS perspective, in that this project, from my perspective, kind of sets the stage for ongoing QI collaboration. It's not something that we've been able to do at present, and so this project kind of set the stage for how that collaboration could look like, how we really work with sites to drive, QI priorities that are important to both of our organizations. And so I think this whole project was proof of concept that collaboration can indeed happen. And so that was just really exciting from my perspective to be able to work with two different organizations and then come up with something that could meet all of our organizational priorities and be incorporated across the system. Steve Yarrow, anything to add there from your perspective?
Maybe just we'll add one piece. So I think having the information being available to people that walk by on the hierarchy posters that we have allows us to be able to understand what some of the shared concerns might be from a resident family standpoint. So if somebody values, having that alone time in the afternoon or being able to go for walks, as much as those things have been very difficult for us in the pandemic, I think we're trying to look at it, okay, from a resident needs standpoint, what are some of the similarities that we can do to improve their well-being, which also improves safety, especially for some of the more complex medical clients in our care.
And I'll just quickly add, because I think it was flagged in the chat as well, is I think one of the catalysts that we're looking for those cards is to provide a much more consistent approach for family engagement as part of these conversations that contribute to QI. So again, with the pandemic, we haven't had a chance to really kind of implement that, but that's ultimately what we're believing the cards will help us do, is this will be the first step to try to figure out how to crack that collaborative decision-making as part of our program and service development.
Excellent.
I know we have 5 minutes left. I'm just going to put someone on the spot here. I see Dr. Vivian Iwa is also on the call. Vivian, is there any comments that you want to make about the project as well? Or Chris? I know Chris Jones is on the call as well, and they're two of our core team members.
No, I think you covered it very thoroughly, Jennifer. I want to just repeat how important it was to have the staff and the residents and their family members involved in the process, and how that really built the engagement and the support for further implementation. So that was critical, as typically we just do quality improvement and then kind of push it on different stakeholder groups to implement. And I think this approach definitely was a much better way to take it forward.
Thanks, Chris.
Yeah, and thanks, Jennifer, Steve, and Yarrow. Excellent presentation. I would agree. And I would agree with Chris, nothing much to add. But I think for me as a physician, I think the aha moment was just knowing that some of the conversations around safety that we always felt occurred in more formal, structured ways or places like in care conferences was not necessarily happening. Really, these were conversations happening very informally. And so empowering patients and healthcare providers, especially the frontline staff, with tools to have those conversations was really the biggest learning point for me. Thank you.
Wonderful. Thank you so very much to to the presenters and to the members of your team. I think it's a wonderful job done. Excellent. I applaud you. Going to move. We have a quick just a couple of things before we wrap up. On measurement, monitoring, and safety. One of the things, we're still here. We're still looking for your wonderful insights, your challenges, your successes, how things are working for you out there during COVID. We have Thea Anthony working with us now, but Anne and I are here, and we would love to hear from you. So please drop us a line. Some updates from our end. Virginia is on board, but Virginia has retired, and it's nice to have you with us, Virginia, here today. Alex accepted a full-time position at the University of Toronto, so Alex has moved on. And we, as I said a second ago, we have Thea here as a new support with the program. We've added some new resources up on our webpage. Thea is going to drop those in the chat box, I believe, for people that you can access. And we are, as a group, we are constantly looking for resources, tools, methods to share measurement, monitoring, safety. So if you come across an article, a tool, please feel free to send it along, to share it with us, so we could also share it with other people. Our next slide, please. So just a little bit of an update. So as many of you are aware, CPSI has been in an ongoing amalgamation with CFHI. And this amalgamation has formally occurred. Jennifer Zellmer, who was the president and CEO of CFHI, is now the president and CEO of the new amalgamated organization with a new board. But while this amalgamation is still ongoing, we are still operating like our programs in both areas are still operating so that we can complete our current operational work plans. So our work plans, we work up to a March the 31st. So we're still trying to work on our current operational plans with a new operational plan to come in the next year. Next slide, please. And we have a quick poll for you. I think, how is this going to work, Thea? I'm going to turn this one over to you. But just before I turn it back to Thea, thank you so very much, everybody, for joining. Hope this was as meaningful to you as it was to me. I took a great deal away from this session. I thank the speakers again. I thank you all for joining and look forward to some ongoing conversations and discussions with people. So over to you, Thea, for a description about the poll.
Thank you. I just dropped the poll link in the chat. So there's only 3 questions. So if you could take a moment to fill that out, that would be greatly appreciated. Thank you, everybody.